Hello and welcome to the North Queensland Primary Health Network Collaborative Quality Improvement Program about cancer screening. I'll be talking about skin cancer. I am Robert Tunison. I'm a fellow of the RSCGP, so I'm a GP. I've done some training with the Skin Cancer College up to the Advanced Diploma of Skin Cancer College of Australasia. More about myself. I was born in the Netherlands. I trained as a GP in Belgium and moved to Australia in 2006, at which point I had seen 2 skin cancers in my career. So as soon as I got here, any day some patient would turn up and ask me, is this something, should I worry about that? And at the time I started looking at these things with this piece of equipment, which is the ophthalmoscope. Now the ophthalmoscope doesn't work really that well to examine skin lesions, and that's how I started training more and learning more about it, and with a very keen interest in surgery. I would have been a surgeon if I had the right attitude or the ego. But eventually I ended up doing a full-time skin cancer at the Skin Repair Skin Cancer Clinic in Townsville. Since 2014, and I'm having an absolute ball there, doing exactly what I love doing. So let's one of that part is indeed screening for skin cancer, checking skin, and we're going to talk about why it is needed, the recommendations that exist, and I would like to brush on some points about the actual examination itself. So why is it needed? Well, the Cancer Council Queensland has a good statistics on that. Melanoma is number 3 cancer in both men and women in Australia, so that's a good reason. The incidence is still increasing, so the slides to the right means it's increasing the incidence. The Melanoma Institute, talking about melanoma mostly because that's still the most lethal one of all, and mainly melanoma is the most important one anyway. So for the Melanoma Institute of Australia, it's the third most common, we knew that, but it's also the most common cancer affecting young Australians, and that is particularly concerning when its incidence is increasing. Also, why is screening important? Because of the 5-year survival. So catching a melanoma early makes all the difference, with a simple white excision being pretty much a cure to any melanoma. Where can we look for recommendations of skin cancer? Well, we always go to the big red book of GP Should, the Guidelines for Preventative Activities in General Practice from the RSCGP. And we come across this first graph here where the main guidelines are really just advice on sun protection all life long, and screening for increased risk and high risk patients. So we'll talk a bit more about advice on sun protection and prevention. What can we say there? So they have a bit of explanation in a graph there. So national campaigns are pretty good. Everybody is familiar with the slip, slop, slap. I'm not sure if you know that that's the seagull, and I've always been surprised why they would take a common garden seagull. I mean, even Nigel the pelican in Finding Nemo says they're just rats with wings. So if your target group is a typical white Australian and you're trying to approach them, why wouldn't you get the Sulpher crested white cockatoo, for instance, which is much more local? Or if you're talking about the damage that sun can do, why not the Royal Galah, which is a much more appropriate colour for sunburn? But in spite of that, it was a great success, and the Queensland Institute for Medical Research, Burkover, they found the melanoma rates dropping, particularly in that young adult group, which is for me a very important factor, because that's where you save the most lives. The same research group as another long-term study back in the 90s. 2 groups split up, 800 in each group, 4-year intervention of providing sunscreen and telling the people to apply it on a daily basis. So daily, not only when you're going out, but every day. And they counted the skin cancers after 10 years, and in intervention groups, about half the melanomas and about 1 or 2/3 of, almost half of the SCCs. A little bit of a difference in the BCCs, and I think in this group you can see how common basal cell skin cancers really are in people. They're probably where 2 in 3 Australians get a skin cancer statistics come from. It's really the basal cell skin cancers, and they're fortunately not that dangerous, but they are a huge burden. So why was that study done? Because actually at the time that study came out, there wasn't really a clear idea of whether sunscreen actually prevented melanoma. And these studies, and mainly observational studies, were a bit all over the place. They were saying some things. Look at that interval at the 1997 study from Whiteman. There wasn't much clarity about it, and in fact it was leaning towards overall research was leaning towards probably didn't make any difference. Adele Green did the first randomized control study that I talked about, and that clearly showed a positive effect of sunscreen on skin cancer incidence. And the immediate reaction, of course, is, well, what about vitamin D? Aren't we going to be falling apart from brittle bones? The interesting thing, the concern correlates with about last decade, that there is an epidemic more of testing rather of osteoporosis. Because what is normal, and this is again QMIR, Bergover, they put that together and are stealing their slides. The advice is true evidence. Cochrane research says it's below 50 is a deficiency, and yet if you look at common or popular advice, it's around 100 to 150, and this accounts for 3/4 more sales. So I think must be a big push from industry to increase the sales of vitamin D supplements. Rather than addressing as a real problem. Here we are. The RCGP agrees when you look at the same big red book. So vitamin D deficiency below 50 nanomoles, and here you see this sort of great group that are sort of by popular definition vitamin D deficient, but actually not by scientific evidence. It might be cynical, but I think there's just a huge dollar factor available there. So how much vitamin or sunlight do you need for vitamin D? Townsville is right here at the high and extreme UV index. So we'll be getting about 8 to 10 minutes is enough exposure, and you will get that just going outside, walking to the car, walking back again. There's a couple of minutes that you'll just get, and that will be sufficient for your vitamin D production, certainly in Caucasians, obviously. So the first advice that I have, put on sunscreen. Use it as a moisturizer, use it as your daily skincare. Put it on before you put your clothes on. I want to skip the formal skin examination for now and go to self-examination, because that's still in the zero line. That's still with the family and with the patient. And I like what they put here. I like the way they explain it in the guidelines for preventive action. So encourage to become familiar with their skin, and that's how I explain it as well. Try and have a look every kind of 3 months is a good sort of Christmas, Easter, and the 2 other holidays. You have a glance over your skin, a bit more conscious glance, and get to know the skin. And it's a great thing that you can do with your family as well. So when you have a family or partner or carer, well, at least somebody can check your back and you can check theirs, and it just greatly improves the surface area that you can check. The apps and smartphones can help. There is not much to it in the various apps that you can buy. There is now a popular the Macroscopic that you can attach to any camera for about $30, I think it is, and that's how probably interesting for rural places, that they can take an image and send it through to somewhere and say, is it worthwhile coming in for it? But there's a lot of pitfalls in that, and I would say, you know, the pictures are helpful now to take an image about something that you're worried about, have a look for a couple of months, see what's happening. If it keeps growing, panic. If it sort of seems to stay the same, consider whether you want a skin check to reassure yourself better, or if you're not too certain of it based on the image you took. But it can help in that way. A bit of change can be detected. But the idea is get to know your skin, make it a habit, same habit as putting the sunscreen on before you put your clothes on. Have it a 3 month for your school holiday, family event. As long as they're not teenagers, it will be possible. A more conscious glance is enough. It really not. You don't have to take half a day out for it. You know, it's got to be able to do it pretty quickly and get a good look. Skin cancer will tend to catch your attention. You know, they do stand out, and if you don't take a temperature, you won't find a fever as a thing. Saying in the book, can't remember what it is, but the House of God here. So if you look, you know, you don't need any training to know that is not proper, that is not normal. So often just looking is enough. And of interest, this was a very early melanoma. It was actually only 0.4 millimeters Breslow depth. So, you know, even though they look big and ugly, they can actually still be quite early, and you don't need to be an expert to see that. So the main thing is, if you've checked and you've seen it, can you sleep well at night? Are you worried? That's the time to get a bit more opinion, you know, and most GPs can just cut it out, in doubt, cut it out, or get a more expert opinion, dermoscopic, and decide whether it needs to be removed or not. Okay, so these are my two advice. I give that to every patient each time they come. Nag them as much as I can. Some people bring in their teenagers, so I can nag them the same thing. Daily sunscreen, preferably an SPF moisturizer on the face. They sink in a lot quicker, a lot more comfortable to use. And self-check every 3 months, a more conscious glance. So it also brings to the now the risk is, how concerned should I be? Should I have maybe 2 monthly checks? Should I do it more often? How much am I at risk? And I get people who are very concerned. So we're talking about identifying risk. So when we're looking at that, and again the RCP guidelines, I do have a bit of an advice on that as well. So the obvious things here are the family history of a melanoma, but I think let's talk about the fair complexity, that complexion. So light-colored people, we know what you mean. The presence of already sun damage, actinic damage, a crusty skin, and we know who they are. This is a very interesting picture. Probably you're familiar with the Fitzpatrick skin type. This is another assessment of it. This is actually not from dermatology. This comes from computer artificial intelligence and facial recognition research. And I like it because it combines the UV image, which is shown to give an idea of the extent of sun damage that is actually present in the skin that patients might not be aware of. And this idea, and the study where I got this image from, is actually refers to the artist who has made these images, actually a YouTube film in 2014, and showing this lady, apparently, you know, nothing wrong with her, and on the RV realize how much UV she has, how much sun damage there is. Also, the video goes on to show what the impact is of sunscreen, and shows how sunscreen protects against UV radiation. A very interesting video, definitely go watch it. The family history of melanoma and the first degree relative, that's the important one. Everybody's got an aunt and uncle who's got melanoma, but it might be emotionally affecting you, but not statistically. It's only the first degree direct relative. Past history of non-melanotic skin cancer, it just means the more SCCs and BCCs you've cut out on a patient, the more likely they are to develop a melanoma over time. Last one is people with childhood high levels of UV light, and this relates immediately to where we are working in the whole NQPHN area, north of Mackay. This is in the annual average, so we had a very high UV rating, and around Cairns it's extreme all year through. So look at July, where Townsville barely makes it out of high, and Mackay is just on the edge of high, and in January it's just off the charts all over our area. So also that translates into the rough numbers for Queensland. We are about 20% of the Australian population. We have about a quarter of all the melanomas, and we have about 40% of all non-melanoma skin cancer. So where we work certainly defines what we should be aware of. Non-melanoma, or the newer term keratinocyte skin cancer, identifying risk, pretty similar, and it's mainly that fair complexion where you get the highest risk. What is really important in these people is the immunosuppressed people. They can have skin cancers that just look like a little bit of a sunspot, but they're actually already skin cancer. They're also prone to far more metastatic disease. Past exposure to arsenic is interesting because it does give quite some spectacular signs on the skin, very, very erythematous and crusty skin. So previous melanoma, and that is always a higher risk. I don't think that requires any further explanation. How should we check? So this is more, do they need formal checks, skin checks? Yes, about every 6 months for the first 5 years. After that, it really depends on how you feel, how they feel, and what you want to do. A lot of them do tend to go back to every 12 months. Dysplastic nevi is a commonly misinterpreted term. All it means is that we're not sure. What is it? Is it a melanoma that doesn't show features of melanoma, or is it a perfectly normal mole that is just going to be a mole and that's it? And when you see patients like this with moles like that, you do know, you need to know what you're talking about, and they are quite a high risk, and I do believe they belong to people for checks with who do them all the time, like our clinic, and there's plenty of other clinics in town. So that brushes on skin examination. So if you're going to do skin examination, there's a lot of text here that I don't fully agree with, but let's see what there is. So a couple of items stand out, like the ABCD rule, the ugly duckling, and let's go over those briefly so we've got an idea. So elevated firm growing is the EFG, very important. Never let them stay in place. If it's got a history of a growing nodule, then always remove it. ABCD is very well known. It's a bit late in my opinion. So the asymmetry, the borders and the colors generally apply to macroscopic views, checks, and the D refers to dermatoscopic clues, and you actually need to know how to use a dermatoscope. Same for the blink. Blink is very practical if you don't have your dermatoscope or hasn't been charged. Obviously you recognize it as a benign lesion, or it is on its own, or it doesn't fit the whole pattern, or the patient is nervous. All those things can help you decide that it needs to be gone. The known, the K of the blink, refers again to dermatoscopic features. And the 7-point, in difference to what the 7-point checklist that is referred to in the RACGP, is actually a dermatoscopic checklist. So I'm not sure how this one is coming from, where it's a macroscopic 7-point checklist. A training in the dermatoscope, to use a dermatoscope, is surprisingly simple, and quite some studies have shown that it takes pretty much a couple of hours. An afternoon training can increase your accuracy tremendously for both melanoma and non-melanoma skin cancer. And using polarized light helps make really quick to do an extensive skin check, even with a lot of moles, because you don't need any contact. So what we use in our practice mostly is 3-point check and chaos and clues. Those are both pathways that can start really small, really simple. Chaos and clues, it tells you already. and you can build your own pathway and put more items in it. What that has helped, we see that in practice as well. Not only the incidence is increasing in melanoma, but the mortality the mortality is actually reducing quite strongly for melanoma, and that means that we're finding more, but we're also cutting them out in time, early stages. So if any day a patient presents to you with, hey doc, is this something? Then I hope instead of wearing your stethoscope and looking like the perfect doctor, maybe you should whip out your dermatoscope, like my colleague Dr. Poggio here, and start looking at it with a dermatoscope. So thank you very much for that, and thank you for listening to this webinar. Have a good day.